Hello everyone, my name is Parul and I'm pleased to welcome you to today's MHS webinar entitled ADHD Transitions from Adolescence into Early Adulthood presented by Dr. Elizabeth Sparrow. This webinar is part of MHS webinar series ADHD Uncovered Strategies for Supporting Youth and Adults. We are thrilled to have you here with us today, and we would like to begin by telling you a bit about MHS Clinical and Education Divisions. MHS Clinical specializes in aiding the identification and treatment of psychological disorders for improved patient outcomes at all stages of life. MHS Education specializes in providing the expertise and resources required to help children and adolescents reach their full potential in and beyond the classroom. With our advanced suite of tools, team of experts, and robust data sets, we help clients provide comprehensive evaluations and uncover powerful insights. During this semi-live webinar, we will start with a pre-recorded presentation by our speaker. After that, we will spend 2 to 3 minutes on our attendance survey, and then we will open the floor for live Q&A with Dr. Sparrow. Our main goal is to make sure you have an enjoyable and educational experience. Now, without further ado, it's my great pleasure to introduce you to our presenter today. Dr. Sparrow is a licensed psychologist in North Carolina, providing neuropsychological evaluations and clinical interventions through her private practice. She is passionate about accurately identifying individual strengths and challenges to inform effective action plans. 30 years of collaboration with Dr. Earhart and the late Dr. Connors led to the co-creation of the Connors Adult ADHD rating scales, that is CARS and CARS 2. Dr. Sparrow has served as lead clinical consultant for the Connors 3, Connors CBRS, and Connors EC. She led skill-based workshops, delivered clinical training, and provided case consultations. She has co-authored a book called Essentials of ADHD Assessments for Children and Adolescents and Guide to Assessment Scale in ADHD, second edition, co-edited Executive Function and Dysfunction, and authored Essentials of Connors Behavior Assessments. We are so glad to have you here, Dr. Sparrow, today. As we begin our presentation, I again would like to quickly remind all of you that there will be a survey sent to you to satisfy the CE credit requirements. If you do not receive this email before the end of the session, then please send us an email at marketing@mhs.com so we can send it to you. Now let's start the webinar. I'm handing over to you, Dr. Sparrow.
Thank you so much, Parul, and thank you to Multi Health Systems for sponsoring this webinar. Helping people with ADHD, especially at this key developmental stage, is so important, and I'm thrilled to be here. In terms of disclosures, I receive honoraria and royalties for these listed items, but these payments do not impact my recommendations for how to help people with ADHD. I can't talk about ADHD without acknowledging decades of fantastic collaboration with Drew Earhart and Keith Connors, as well as the many talented professionals at Multi Health Systems who provide us with tools to support people with ADHD. For the narrative learners in the group, I'd like to start with a story about 3 people who have ADHD. They attended the same schools growing up and enjoyed the same clubs and sports teams. They took honors and advanced placement classes and earned mostly A's with a few B's. They all accepted offers to attend the same competitive state college. One, who we'll call Abir, was diagnosed with ADHD in middle school. Abir had a 504 plan and learned to request and use accommodations. Abir had a daily study hall in high school that included time management and study skills. Abir's parents were available when needed, but they were not involved in daily academics. Abir worked with a therapist to learn coping strategies and with a psychiatrist for medication management. Zev was also diagnosed with ADHD in middle school. Zev had a 504 plan and the support of private tutors. Zev's mother reviewed homework every day and monitored all teacher communications to make sure nothing slipped through the cracks. She proactively contacted each teacher before every paper, project, or test to ensure Zev received appropriate accommodations. She bought extra copies of all assigned books so she could read and discuss them with Zev. Zev worked with a private provider for medications and mindfulness. The third person, Makalo, had no history of diagnosis, accommodations, or interventions at the time of high school graduation. Their final grades reflected pandemic policies that allowed students to retake tests and submit late work for full credit at the end of each semester. Without these flexible grading options, their transcript and GPA would not have been as impressive. Their high school English curriculum included drafting and revising college application essays in class, as well as school support with submitting their Common App for college. Today's webinar topic matters because each of these students matters. I imagine each of you has a reason you are motivated to help people with ADHD as they move from adolescence into adulthood. I encourage you to think about their stories as we work through today's content. Now, for the data-driven learners, here are some facts about why today's topic matters. About 90% of children diagnosed with ADHD continue to struggle in early adulthood. Reviewing records of adults with ADHD, 75% of them were not diagnosed until adulthood, and over half of these newly diagnosed adults had tried to get help earlier. More people are looking for answers today. For example, Google searches for ADHD increased from about 70,000 in 2019 to over 170,000 in 2023. That's a 141% increase. This increase is not entirely due to the COVID-19 pandemic. The incidence of first-time adult ADHD diagnoses nearly doubled from 2007 to 2016. The bottom line is, we need skilled providers who can answer questions and provide knowledge, not misinformation. Today's target audience is the professionals who diagnose and treat ADHD. While I firmly believe it's important to provide information to parents, teachers, attorneys, general public, and people with ADHD, I routinely talk with people from all of these groups, but that's not the purpose of today's webinar. If you're from one of those groups and listening today, please reach out after the presentation so we can connect you with additional resources for context and background. This webinar is intended to extend foundational information provided in your training. If you'd like additional information about assessing ADHD in adults, please consider the 2023 webinar that Drew Earhart and I recorded as part of MHS's series. You can scan this QR code to get to the webinar. During today's webinar, you will gain information to answer the following 5 questions. Why do people present for ADHD services in late adolescence and adulthood? What changes as people with ADHD move into adulthood? What's different in the DSM-5 TR for older adolescents and adults? What areas of functioning are vulnerable to impairment for adolescents and adults with ADHD? And how can each of us make a difference for people with ADHD in this age group? And if you know me, you know I like structure. So here's the outline we're going to be following today. So, seeking services. Why do people seek ADHD services in adolescence and early adulthood? People tend to seek services when things get hard. The developmental tasks associated with this life stage are hard for everyone, and particularly so for people with ADHD. People are faced with increased expectations like independence, not only academic, but also self care, paying for expenses, and discerning which choices will pay off long term instead of choosing what feels good right now. There's decreased levels of structure and support, like less supervision, no parents on site, and reduced contact with familiar people. So there's nobody to recognize early indicators that things are getting off track. Temptations are readily available with fewer safeguards. Temptations like staying up all night, skipping meals, drinking until drunk, and so on. And the consequences of these actions as an adult carry higher stakes, like being arrested instead of getting detention, or being fired for subpar work instead of getting lower grades. When you add ADHD to this difficult developmental stage, things get more complicated. Research shows people with ADHD have exacerbated impairments around the time of transition to adulthood, in contrast to relatively stable impairment in peers without ADHD. We'll return to this topic in a bit. People are more likely to seek services about things that are in the public eye. There are positive aspects to public awareness, such as sharing accurate information through efforts like ADHD Awareness Month. Social media can reduce stigma, lead to greater awareness of symptoms, and encourage people to seek diagnosis or treatment, such as described by Matilda Bosley in her 2021 editorial. Unfortunately, social media does not always have a positive impact. Overall, social media references to ADHD have increased significantly. In January 2023, hashtag ADHD had over 3.9 million posts on Instagram. TikTok videos with this tag had over 4.3 billion views. Can you guess which videos had the most likes and views? Personal experience videos. A study of the top TikTok ADHD videos identified 52% of them as misleading. Only 5% of these top videos were considered useful by a team of expert reviewers. The way social media algorithms work, it's more likely that after viewing one inaccurate post about ADHD, that you will be led to additional inaccurate posts. Furthermore, the characteristics of ADHD mean that these teens and young adults are more vulnerable to social media. It makes sense, right? Given what we know about self regulation, restlessness, seeking fast paced input and high levels of stimulation, instant gratification, and short attention spans. Some people with ADHD say that social media fills fidgeting needs. Research shows that adolescents with ADHD have higher intensity use and more problematic use of social media. Teens with ADHD tend to share too much personal information and post more tweets in general, especially at night. One study of teens with ADHD found average use of media after 9 p.m. was over 5 hours a night, which means they're not getting enough sleep to function well the next day. Why else do adolescents and young adults show up in our offices with questions about ADHD? A new reason we weren't talking about 5 years ago is pandemic related awareness of needs. People who noticed a loss of structure during work from home and virtual learning, or an exacerbation of ADHD symptoms when combined with the brain fog of COVID. People reported higher levels of ADHD symptoms during the pandemic, including both people in the general population and people who were already diagnosed with ADHD. People tend to seek services when compensatory strategies are not working like they used to. Examples like really smart people who were able to get by, but eventually they encounter a challenge where being bright is not enough. In the ADHD clinic at Duke, these referrals included really high IQ undergrads, law students, medical students. It's essential when evaluating and treating these bright individuals to look beyond average performance at work and school and examine the cost of compensation, like the loss of social time, the loss of leisure. People who had high levels of support and structure in childhood and adolescence often lose these external supports when they move into adult life. Supports like parents who give repeated reminders of appointments and deadlines, households where things are invisibly taken care of, and school settings with consistent routines and schedules. And people are dealing with new challenges as they enter adulthood. Things like getting along with roommates, taking care of a pet, raising a child, paying bills, keeping up with chores, buying groceries, preparing meals. One more age related reason for seeking ADHD services is when people need updated documentation for things like the SAT, ACT, AP exams, college accommodations, and workplace needs. These are common reasons that people show up for ADHD services in this age group, particularly in our current climate of increased public awareness. Let's turn to our second major topic, how ADHD changes during this developmental stage. Knowledge about ADHD in childhood is not sufficient when working with adolescents and young adults. Symptoms may be less visible, and the diagnostic criteria change. The opportunities and challenges of adulthood can be very different from those in childhood. How does ADHD change in this age group? Research suggests that features of inattention are more likely to persist into adulthood, whereas the DSM symptoms of hyperactivity and impulsivity become less evident. Some of this may be due to internalization or strategies such as environmental engineering. Even in people who were clearly hyperactive as children, the obvious motoric symptoms often become less observable as they approach adulthood. It's important to ask about internal experiences like restlessness, difficulty relaxing, or wanting to avoid inactivity. Instead of relying entirely on visuals like fidgety fingers, ask about body movements. For example, it's hard to observe fidgeting when someone is quietly tapping their toes inside their shoes. Overt impulsivity, like grabbing things, often shifts into subtler symptoms like feeling impatient, not recognizing boundaries, risk taking, and outbursts. And then the attention and executive deficits associated with inattentive features are often masked. Consider asking about how people get their work done. Are they having to work evenings and weekends? Are they getting coworkers to cover for them? Standardized rating scales are really helpful for detecting these symptoms as people move into adulthood, like the Conners Comprehensive for adolescents and the CARS 2 for adults. These help you capture areas of concern with age referenced comparisons to capture developmental expectations. Given that symptoms of ADHD often shift as people move into adulthood, it makes sense that our diagnostic criteria would need to change as well. Remember that the original DSM diagnostic criteria were based on childhood presentation because at that time, the leading view was that children outgrew their symptoms. As evidence mounted showing that ADHD persisted into adulthood, this began to be acknowledged in subsequent revisions of the DSM. The DSM-4 improved on previous versions, but it still applied a one-size-fits-all set of criteria across all ages. Our most recent criteria in the DSM-5 TR reflect that ADHD persists into adulthood, that there are some differences in presentation, and that sometimes people are not diagnosed until adulthood. The DSM-5 TR criteria define older adolescents and adults as people 17 years and older. Key changes include the number of symptoms required. Remember that a childhood diagnosis requires evidence of at least 6 symptoms within a category, that is, at least 6 inattentive, or 6 hyperactive impulsive, or 6 of each for combined presentation. But it's often hard to reach 6 symptoms per category for adults, which meant some adults with significantly impaired functioning were not able to be diagnosed under the DSM 4. Dropping the threshold to 5 symptoms, as the DSM 5 did, is more realistic for adults, particularly those without readily available childhood records. The DSM 4 did not provide any examples, much less age related examples. The DSM 5 expands our understanding of how each symptomatic criterion can present. For example, the symptom distracted by extraneous stimuli now indicates may include unrelated thoughts. Avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort now includes the example, such as preparing reports, completing forms, reviewing lengthy papers. The symptom is often forgetful in daily activities now includes examples such as returning calls, paying bills, and keeping appointments. And often runs and climbs at inappropriate times now indicates may be limited to feeling restless. The third thing I want to comment on about the DSM 5 criteria for older adolescents and adults is the age of onset criterion. Pay attention because it has two key changes. It's not just about the age, although that is an important shift from before age 7 to prior to age 12. Also notice the change in wording. Instead of requiring that a symptom caused impairment to be counted, the DSM 5 only requires that the symptoms were present before age 12. These revisions make sense because adult self-report is more reliable for early middle school, around 11 or 12 years old, than it is for early elementary school. Also, for older adolescents and adults presenting for first diagnosis, early childhood symptoms were sometimes masked by IQ or home and school supports, which would limit evidence of early childhood impairment. Those are the big changes that apply for at 17 years and older. But it is essential to remember that these specific changes are in a larger context. The DSM 5 continues to require that symptoms persist over time, that they are inconsistent with developmental level, that they have a negative impact, that they are present in more than one setting, and that there is evidence that symptoms interfere with functioning. As always, there are key rule outs to consider in differential diagnosis. So, just a summary caution for use of the DSM 5 with older adolescents and adults. Remember to differentiate clinical levels of symptoms from those that occur on the normal continuum. It is essential to consider all parts of the DSM criteria instead of relying on an 18-item symptom checklist that only represents Part A. Okay, we've talked about changes in presentation and changes in diagnostic criteria. Another big aspect of change for adolescents moving into early adulthood is the opportunities that become available. Most traditional primary and secondary schools have fixed schedules and requirements, making all students follow the same format. As ADHD teens enter adulthood, they can seek good fit niches, such as finding jobs that allow or even encourage movement, outside the box thinking, and creative leaps. Choosing people to partner with, such as friends and roommates who like fast paced, thrill seeking activities and spontaneity, in contrast to living with parents who may be frustrated by echoes of their own childhood struggles or who are unable to understand why their child is so different from them. Creating a daily or weekly schedule that allows short bursts of effort on certain tasks and long marathons of hyper focus on others, with movement and brain breaks as needed rather than having to wait for the school bell to ring. Identifying coworkers and supervisors who provide immediate point of performance feedback and high degrees of interaction, people who can serve as accountability partners. Selecting work and study settings with a just right level of stimulation in terms of temperature, background noise, and visual distraction. And hiring staff like executive assistants. There's no mistake in that title. House cleaners, personal organizers, nannies, pet walkers, etc. Unfortunately, there are also some negative aspects of ADHD as teens enter adulthood. As youth with ADHD grow older, quality of life gets worse in physical, emotional, and school domains. Parents of youth with ADHD also experience lower quality of life. Children and adolescents with ADHD show more impairment across domains than their non ADHD peers. Impairment tends to persist into adulthood, even when symptom count decreases. It's essential to investigate these areas of impairment. In addition to it being part of the diagnostic criteria for ADHD, impairment is often the primary reason someone seeks services. It can be a key target in treatment planning. All of us who worked on the newest Connors scales felt so strongly about this that we included impairment scales on the Connors 4 and the CARS 2. I hope I can convince all of you that we must pay attention to impairment when we serve people with ADHD. So join me as we take a deep dive into aspects of impairment that are associated with ADHD, particularly for teens and young adults. As we review data on impairment, remember that statistics from research studies generally describe groups of people. Even if something happens to 99% of a sample, your client may be the 1% who it does not happen to. The impairment statistics help us pay attention to important areas. They do not tell us what will happen to an individual. With that in mind, I still want each of us to process statistics with humans in mind. As we review research findings about ADHD related impairment, remember this picture of teens hanging out. Imagine how this group could get smaller if each area of impairment interferes with their road to adulthood. Now, because I'm a therapist who believes in a growth mindset, I also want you to visualize how you can improve the odds for your students, patients, clients, how you can help more of the youth in this picture reach the goals in their life. Let's think about how social impairment looks. Research consistently shows that youth with ADHD are more likely to have social issues. Social impairments impact friendships, family relationships, and romantic connections. Adults with ADHD report higher rates of loneliness and social problems. They tend to have worse social skills and fewer friends. Adolescents with ADHD and their parents have conflicts over more issues than their peers without ADHD. And students with ADHD tend to have worse social adjustment during college. Young women with ADHD typically have fewer romantic relationships and increased conflict with their mothers. The parent child relationship is further complicated because many youth with ADHD have a parent with ADHD, and there are clear findings that ADHD impacts parenting. Adults with ADHD have shorter romantic relationships, higher rates of marital dissatisfaction, and higher rates of divorce. Those who stay married often have more negative perceptions of family life and marriage than their own spouse does. These social impairments can become a double whammy in terms of how other people respond to people with ADHD and how people with ADHD respond to others. One study observed social interactions and found common responses to people with ADHD included negative mood, hostility, and rejection. On the flip side, relationship skills are often hard for people with ADHD, like listening, attending to details, keeping track of important events, and resisting urges to take over conversation. There is some good news. When people with ADHD are able to form meaningful relationships, they have improved long term outcomes. So it is worth working on these skills. Turning to emotional vulnerabilities, they often appear at this transition from teen to adult, including both subclinical risk factors as well as diagnosable anxiety and depression. Research shows that youth with ADHD have heightened reactivity to novel or stressful events. Adults with ADHD have elevated emotional dysregulation, and low self esteem is common in women with ADHD. 80% of adults with ADHD have at least one co occurring mental health disorder, and over half of adults with ADHD have two or more co occurring mental health conditions. 47% of people with ADHD have an anxiety disorder, 38% have a mood disorder, and at least 15% have a diagnosable substance use disorder. People with ADHD have increased rates of suicide ideation, attempts, and completions. For example, one study of a young adult ADHD sample found 15% of them had attempted suicide, as compared to 0% in the control group. There is some good news here that ADHD medications are associated with reduced risk of depression and with a decline in suicide related events. One general comment here, there are more published research studies about the impact of medication than about the impact of other interventions. Don't let this publication bias slant your view of what works. Turning to behavioral impairment, this includes things like substance misuse and risky sexual behavior. For substance use, this is a bidirectional finding. When you study people with ADHD, you find much higher rates of nicotine dependence, alcoholism, and other substance use disorders. And conversely, when you look at people who misuse substances, such as cocaine, alcohol, and opioids, there is a high prevalence of ADHD, about 1 in 5 people. A study of teens and young adults with ADHD indicated about 80% had used an illegal drug versus 51% in the control group. About 20% of the ADHD group had cannabis dependence or abuse versus 1.5% in the control group. And about 30% had alcohol dependence or abuse compared to 6.2% of the control group. Although most general population adolescents reduce substance experimentation as they enter adulthood, those with ADHD showed increased drinking as young adults. People who also have ADHD in addition to a substance use disorder have an earlier age of substance use, faster escalation from casual use to addiction, higher relapse rates, and more substance-related hospitalizations. By college, ADHD is associated with greater likelihood of substance use, more frequent use, and more risky use, like binge drinking. I always look for where I can find good news. The piece of good news here is that even though there were old fears that stimulant prescription might lead to higher rates of substance abuse, modern analyses show consistently that well-treated ADHD is associated with lower rates of substance misuse. Moving from substances, let's look at risky sexual behavior. Adults with ADHD combined presentation self-report higher rates of risky sexual behavior than reported by adults without ADHD, 24% versus 4%. Specific risks include sex at an earlier age, less consistent use of birth control, more sexual partners, higher rates of sexually transmitted infections or STIs, and higher rates of teen pregnancy. As with substance misuse, teen pregnancy has bidirectional findings. A longitudinal study followed girls who were diagnosed with ADHD in childhood. 43% of this group reported an unplanned pregnancy at follow up, compared with 11% of the non ADHD sample. Shifting perspectives, studies of pregnant teens often find high rates of ADHD. There was an interesting study of young adults with ADHD that identified high rates of predicting positive benefit from risky sexual behavior and low rates of predicting negative outcomes. In other words, the focus was on pleasure with limited consideration of potential risks. Encouraging findings in this area include that well managed prescription use is associated with lower rates of teen pregnancies in girls with ADHD and lower rates of STIs in teenage boys and young men with ADHD, which suggests that controlled impulsivity reduces sexual risk factors. Turning to legal vulnerabilities and impairment, people with ADHD tend to get their driving license later than same age peers. Looking at the first 6 months of eligibility, about 35% fewer teens with ADHD pursue a license. While you might hope that the additional time would be beneficial, waiting until later ages does not seem to improve the crash statistics. A study of teen drivers in New Jersey indicated that teens with ADHD were more likely to crash and to be at fault in their first year of licensure. Their crash rates in the first 4 years of licensure were 37% higher than same age new drivers without ADHD. There is some data to show use of medication can mediate the relationship between ADHD and crashes. Overall, it's not surprising that there are more crashes for people with ADHD, given that there are higher rates of reckless driving, like collisions and speeding. A recent analysis found that 35% of adults with ADHD combined presentation endorsed risky driving, compared with only 5% of adults in the non-clinical sample. History of childhood ADHD is associated with higher rates of driving without a license, traffic tickets, and multiple license suspensions. Moving away from driving issues, there are also bidirectional relationships between ADHD and incarceration. People with ADHD have higher rates of criminal convictions than seen in the general population, and surveys of corrections populations consistently find high rates of ADHD. Young adults with ADHD have higher rates of arrest than peers. Keep in mind that being arrested does not necessarily mean someone is guilty. Another study found adolescents and young adults with ADHD are more likely to make a false confession. In general, offenders with ADHD have higher rates of recidivism and faster reoffense. Good news in the legal arena includes findings of reduced crime rates during periods when adults with ADHD were taking prescribed medications. Another legal concern for our clients with ADHD is risk of dating violence. Adults with ADHD are more likely to commit dating violence and also to experience dating violence. When there are episodes of intimate partner violence by adults with ADHD, they tend to include psychological aggression and minor physical aggression, not typically severe physical aggression, injury, or coercion. And it is encouraging to know, as symptoms of ADHD decreased in treatment, psychological and physical aggression in dating relationships decreased as well. Okay, we're about halfway through the impairment categories. We've covered social, emotional, behavioral, and legal concerns. Let's look at ADHD outcome data for education and employment. Academic success for students with ADHD can be complicated by co-occurring diagnoses like dyslexia. Some studies find up to 40% of students with ADHD have a comorbid learning disorder. On the whole, people with ADHD tend to underachieve academically, drop out of school, and have delayed high school graduation. Uh, Treatment with medication is associated with increased GPA and a higher probability of graduating high school. Students with ADHD who pursue college education are often impacted by issues with time management, concentration, organization, and procrastination. And these young adults with ADHD are significantly less likely to graduate college than same age peers. A recent meta analysis found that only 5 to 17% of participants with ADHD earned a bachelor's degree, as compared with 30 to 56% of the control group. Educational impairment has an impact on employment, in addition to how ADHD symptoms directly affect on the job performance. Studies show that adolescents with ADHD have reduced rates of employment and lower earnings, even compared to their siblings. ADHD adults have lower rates of full time employment. Even in educated, medicated adults, ADHD is associated with work impairment. One study found 98% of an adult ADHD sample had some level of impairment at work. 73% of this sample reported moderate or worse levels of impairment. Adults with ADHD have higher rates of negative performance reviews, being laid off, and being fired. There are higher rates of coworker conflict and supervisor discipline. Adults with ADHD on average have more late arrivals and miss more days of work. When they are present, adults with ADHD tend to be less productive at work, and they have increased rates of quitting without a plan. Education and employment feed into financial outcomes. People with ADHD who are employed, on average, earn less than their peers and have lower household incomes. One study found that participants with history of childhood ADHD had financial health that worsened through age 30, predicting reduced lifetime earnings of about $1.27 million each. Surveys of young adults with ADHD found 25% of them were paying living expenses with money from their parents, as opposed to 12% of their non ADHD peers. And on average, people with ADHD have a harder time holding on to the money they earn. ADHD is associated with an increased risk of problem gambling and overspending, as well as impulse buys, overextended credit, and late payment penalties. After adjusting the balance of a savings account to reflect the amount of debt owed, young adults with ADHD have 80% less money in reserve than their non ADHD peers. The last aspect of impairment we will cover today is how ADHD impacts physical health. Factors to consider in this category include how symptoms of ADHD can increase likelihood of injuries, decrease speed of seeking assistance, and reduce follow through with treatment recommendations and follow up appointments. Overall, data show that people with ADHD have increased mortality and reduced life expectancy, often due to accidents. One study estimated a 9 to 10-year reduction in life expectancy for people with a childhood history of ADHD. Adults with ADHD are 50% more likely to be obese than their non ADHD peers. There's a high rate of co occurrence between ADHD and allergies, asthma, and eczema. Type 2 diabetes is 70% more prevalent in ADHD adults compared to non ADHD peers. And sleep issues are common for people with ADHD. Some of you may recall the DSM-3 included the symptom moves about excessively during sleep. This is no longer part of our diagnostic criteria, but ADHD is certainly associated with sleep issues such as sleep disordered breathing, difficulty falling asleep and staying asleep, not feeling well rested in the morning, and restless legs syndrome. Accidental injuries are more common in people with ADHD, including sprains, strains, contusions, burns, and broken bones. Youth with ADHD are more likely to sustain a concussion than their non ADHD classmates. And dental concerns occur at higher rates for people with ADHD, including tooth decay, more plaque, grinding, and clenching. And adults with ADHD are less likely to follow through with regular dental care. One study found only 36% of the adult ADHD sample kept up with dental appointments. So, I'm glad to be finished with that laundry list of impairments. I want to talk to you about how we can make a difference. There are many challenges that face these adolescents and young adults with ADHD. Um, these impairment statistics describe groups, but we have the opportunity to work with individuals to open new doors as these people move from adolescence into adulthood. Keeping our professional skills sharp and our knowledge updated helps us be smart with recognizing and asking about issues. When we're balanced in our approach to diagnosis and treatment, we are better positioned to help our clients create balance in their lives. We can guide skill development that builds and sustains a teamwork approach. So let's look at how enhancing our professional skills will help us better recognize when ADHD is present and when it is not, how this helps guide our response to people with ADHD. Our knowledge of how ADHD changes with age, including presentation and diagnosis, gives us a strong foundation. Smart strategies to support this skill include review the DSM-5-TR every time you evaluate an adolescent or young adult, particularly the age-related changes we discussed earlier today. Select standardized evaluation tools that are linked to strong normative samples to help identify age-based expectations. Remember that the DSM specifies behavior must be inconsistent with developmental level to count as a symptom, even in adults. And given that some features of ADHD are less obvious in this age group, remember to ask people about their internal experiences. For example, ask how it feels when they must be quiet and sit still. What strategies do they use to get through these situations? How much effort does it take? And do they have to decompress afterwards? Building on this foundation, pay attention to domains of functioning and examples of impairment. This is essential for both diagnosis and for treatment. The DSM-5 reference impairment in two places in their diagnostic criteria for ADHD. Criterion A specifies a behavior must negatively impact directly on social and academic occupational activities to count as a symptom. And criterion D requires clear evidence symptoms interfere with or reduce the quality of social, academic, or occupational functioning. And from a treatment perspective, recognition of impairment can help identify treatment targets, skills to be taught, and necessary supports and accommodations. Knowledge of intact functioning versus impairment can inform goodness of fit considerations. Research tells us that relief of symptoms does not necessarily translate into improvement from a client's point of view. Interventions that target areas of impairment are more likely to lead to a positive outcome from your client's perspective. Now, this last bullet is interesting. Historically, I would not have advised watching Instagram and TikTok as part of professional training. but maybe we all need to rethink that perspective. Knowledge of what's being posted on social media about hashtag ADHD can help us recognize key phrases that suggest someone's referral came from Dr. TikTok or Dr. Instagram. We can gather facts and prepare explanations to counter online myths. Consider asking your clients where they found information about ADHD. Worst case scenario, you'll get a chance to provide education. Best case scenario, you might learn about a reasonable resource that could be helpful to other people. We can make a difference by helping clients learn how to intentionally cultivate balance in their lives. We can model balance through a whole person approach by asking about successes as well as challenges. This is how we want our clients to approach their lives, and we can help them practice this mindset. Consider going beyond deficit detection in assessments and interventions. It only takes a few minutes to reflect on things that are going well in a testing profile or in someone's life. Pay attention to exceptions. For example, if someone has difficulty focusing most of the time, but finds it easy to focus when designing online invitations, they might seek classes or jobs that have an online interactive format. Provide education about ADHD and related topics like impairment. Knowledge is power. After identifying a whole person balanced profile, leverage this information to identify components of a good fit setting. Explain the concept of goodness of fit. Sometimes it helps to use the image of forcing a square peg into a round hole versus looking for a square hole. I have found I usually then have to explain that yes, it is technically possible to make that peg fit, but it's going to take more time, energy, and effort. When you have permission to share this perspective with family members or members of the treatment team, it can help to have universal language to support this perspective for our clients. Another thing I talk about in terms of leveraging information is the idea of environmental engineering. This includes ways to adjust the environment to compensate for ADHD vulnerabilities by reducing drains on a person's internal strengths. When I discuss this concept, sometimes I use the image of carrying a gas can to a stranded car. Would you rather arrive with a full can of gas or use a can with holes that drained as you walked, leaving only a small amount of gas when you arrived? Environmental engineering can help keep an ADHD brain full of resources instead of draining them on things that don't contribute to work success. Identifying accommodations and modifications that improve access to school and work is another way that we can leverage someone's profile. For example, a student might better demonstrate their knowledge when they take tests in a private setting with only one exam per day. An employee might be more productive if allowed to shift their work schedule to capitalize on when medications are active and the office has fewer distractions. A third way we can help our clients with balance is by strengthening protective factors to offset risk factors associated with ADHD. We've just spent a lot of time talking about many vulnerabilities and impairments that are associated with ADHD at this age, so it makes sense to balance the scale by explicitly teaching and practicing coping strategies. Being intentional about identifying problems and finding solutions, not only in life's logistics, but also in social and emotional solution finding. Talk about how to recognize, process, and express basic emotions. All of these skills lead to stronger resilience and faster recovery from difficulties. Consider each person's social and emotional well being in your sessions. ADHD does not happen in isolation. It can and it does occur in complicated contexts involving anxiety, depression, and messy boundaries. Self care is another key protective factor, including for ADHD. Most of my therapy clients can easily list their personal self care targets because we talk about them all the time. They will tell you about things like sleep, nutrition, hydration, physical activity, planned leisure activities, and downtime. When the brain and body are not physically maintained, it's hard for other stuff to happen. Now, these protective factors cannot always prevent co occurring conditions like anxiety, depression, and substance misuse. But protective factors can improve outcome by delaying onset of symptoms, reducing severity, decreasing length of episodes, and minimizing impairments. Learning these balance skills as a teen or a young adult helps people with ADHD launch more successfully into their adult lives, which improves the odds of a positive outcome. Our last topic today is how teamwork can make a difference for people with ADHD. Just like a brain surgeon or an Olympic athlete is surrounded by a support team, each person with ADHD needs to have a strong network of supports that is based on their unique profile and circumstances. Team members to consider include people like a counselor or therapist, prescribing professional, job coach, executive functioning coach, study skills tutor, a support group. Probably not all of these at the same time, but maybe all of them in the big picture long term plan. Having the right support team is not enough, though. It's essential for each person with ADHD to be able to build a bridge from knowledge to action. Education and conversation can help establish a foundation of self awareness. Try presenting one factoid at a time, then guide reflection about when this may have been true for your client. Share your own observations and see if your client is surprised. Ask if others have ever commented on similar things. These strategies can help increase awareness for people with ADHD, which is the foundation that has to exist before a bridge can be built. Acceptance is the next necessary piece. When a person with ADHD does not believe that they have a need, they are unlikely to pursue effective communication or self advocacy. Furthermore, if they are pouring energy into hiding their needs in hopes that nobody will know, they will not have the bandwidth to manage everyday life. Once awareness and acceptance are in place, the next step is improving communication skills. People with ADHD, no matter what their IQ is, often benefit from direct instruction in identifying a core message, keeping it concise, and choosing when and how to communicate. The last construction phase for this bridge is self advocacy, knowing what you need and effectively communicating it to make your life better. Self advocacy is an important skill for any teen or young adult, and it is especially critical for people with ADHD. Use skill instruction and role play to develop and strengthen self advocacy until it becomes a habit. I have one more thought about teamwork, and that is helping our ADHD clients learn how to communicate with their team before they land in a crisis. A big part of this is looking ahead to see beyond the immediate. Difficulty with pausing to consider long term perspectives is part of ADHD for many adolescents and young adults. But this skill can be developed as a habit through direct instruction and guided rehearsal. Get creative to build a strong visual analogy, as this can be a great shortcut in your conversations, and it makes the concept more likely to stick for the person with ADHD. Here's an example that's pretty easy to draw, even for people like me who are not very artistic. These blobs are meant to be potholes on the road. The goal here is not making art, but making a visual anchor for attention and cueing key discussion points. When I use this in therapy, I have people make notes on their picture. So it becomes a way of remembering and rehearsing the concepts from our conversation. Looking at the labels, past traps reminds us to explicitly review past situations, responses, and outcomes so we can start looking for patterns. Now reminds us to identify current challenges and then use the session to actively practice using strategies. The next step here is trying to recall what happened just before the current situation, which builds again that ability to predict and anticipate. The things that happen just before a current trap can be labeled as warning signs. Athletes sometimes like using the language of yellow flags and red flags for this cue. Recognizing these warning signs leads to anticipation of future traps. Some clients with ADHD do well with actual physical or digital reminders of what their own warning signs are. For example, they might put a post it note on the bathroom mirror. College kids can put the note inside their closet door. You can set a recurring reminder on your phone. The goal with these physical reminders is a daily review of personal warning signs so that you have increased awareness and recognition when they happen. The final step in this process, well, it's not really final because the process repeats itself. So the next step is cultivating ways to recover when in a trap. This can take the form of a note to self, like, when I feel stuck and overwhelmed, whatever the person's word is, I can. And then 2 or 3 strategies that have worked in the past, like, I can call my therapist, I can check my self care, I can use 5-finger breathing. A tangential comment about this visual, I like to include whole person reminders and analogies and pictures. In this example, notice the person has a backpack and a walking stick. These represent the skills and strategies they are carrying with them every step of the way. As we wrap up this webinar, I'm going to return to the narratives about 3 people with ADHD, all of whom were accepted into the same competitive college. Let's see what happened next for them. You may recall that Abir had a head start with diagnosis prior to high school. Abir not only learned strategies, but also had the opportunity to apply them. Abir's protective factors helped reduce risk factors and impairments. When challenges arose, Abir knew to look for resources in college and was able to connect with necessary supports for success. For example, Abir learned that 15 credit hours was too many, and they decided to focus on succeeding with 12 hours a semester. They planned to take an extra year to finish college. Although Zev also had the advantage of diagnosis during middle school, their post-graduation story was rocky. Zev had learned to rely on parents for support and structure. Because skills were not internalized or rehearsed, Zev floundered in college. Newfound freedoms led to partying at night, sleeping in the day, and several trips to the health center for strep throat, a sinus infection, and dehydration. Zev ignored emails, phone calls, and letters from professors and advisors. Inevitably, this pattern led to failing grades and dismissal from the program. Zev returned home to focus on playing video games and sleeping with extracurricular activities that included various substances. Despite significant parent efforts, it was challenging to re-engage Zev in coursework, employment, or treatment. Eventually, Zev agreed to participate in a residential recovery program, followed by a half-day intensive outpatient program back at home. They completed an associate's degree through a community college while working part-time and have been accepted as a transfer student to return to the state college. Our third student, Makalo, is the one who went to college without a diagnosis. Makalo had a rough first semester. Their high school experience of penalty-free extensions and test retakes was not offered in college. When McCullough received a midterm warning of possible suspension, they met with their academic advisor, who connected them with the campus counseling center. A community provider completed an assessment and diagnosed ADHD. This provider worked with McCullough and the college to make a plan that included weekly academic tutorials, wellness courses through student health to improve self care and time management choices, and a peer buddy to support accountability with following through on personal goals. After a year of these supports, McCullough was making progress, not only with academics, but also with skills and strategies to support life success. I encourage you to reflect on the areas of impairment reflected in these stories, as well as on the skills you could introduce to these students to improve their outcomes. I hope you consider all of the information from today's webinar as you think about the people you see for evaluation or treatment, and that you find some of these ideas helpful in your work. And finally, for those of you who prefer key facts over narratives, let's review our 5 original objectives. Why do people present for ADHD services in late adolescence and adulthood? We discussed a variety of reasons. The transition from adolescence into adulthood is hard, especially for people with ADHD. Developmental factors, increased public awareness, response to the pandemic, shifts in compensatory supports, and environmental complexities all lead to seeking services. People with a childhood diagnosis of ADHD often return for updated documentation at this age point. How does ADHD change as people move from childhood into adulthood? For many people, symptom presentation becomes subtler, more internalized. In some cases, strategies can make symptoms less obvious. Young adults may experience feelings of restlessness and impatience in contrast with physically running around and grabbing things impulsively in childhood. Inattention may be masked by working extra hours or over reliance on others. What's different for older adolescents and adults in the DSM-5 TR diagnostic criteria? Key changes for people 17 and older include fewer symptoms required per category, just 5 instead of 6. More examples of how presentation differs with age, like internal distractibility, and changes to age of onset, namely presence of symptoms by age 12, rather than evidence of impairing symptoms before age 7. These are the age-related changes in the DSM-5, but the diagnostic context remains constant over the lifespan. Responsible diagnosis still requires persistence over time, developmentally inconsistent, negative impact, pervasive over settings, impairment, and rule outs of other explanations for the symptoms. While opportunities associated with entering adulthood was not explicitly listed as a learning objective for this webinar, we covered a number of ways adults with ADHD often have more options than children do in terms of good fit settings for life. What areas of functioning are vulnerable to impairment for youth and adults with ADHD? Pretty much all areas. I bet you can recall examples from social, emotional, behavioral, legal, financial, education, employment, and health-related areas. I hope our review of these outcome data has convinced you that it is essential to ask about impairment in evaluations and to include it in treatment planning. Last, and probably the most important, what strategies can I use to make a difference for an adolescent or young adult with ADHD? Each one of us has our own professional style, and each person we serve will respond to different approaches. It is unlikely that any of us will use all of the strategies discussed with one person. But hopefully, you are leaving here with a backpack full of options to consider when your old familiars are not working. In addition to the professional skills that you have around detecting age-related changes and areas of impairment, we talked about becoming familiar with social media. We examined ways to increase client balance through describing a whole person profile, leveraging that to find good fit settings, and strengthening protective factors to balance risk factors. Finally, we discussed helping our clients be connected to teamwork, including assembling a strong support team, building a bridge through awareness, acceptance, communication, and self advocacy, and proactively anticipating future challenges to know when to activate the support team. We enter the lives of our students, patients, and clients at different points in their story. No matter when we join them, we can give them options to consider. Knowing common reasons why people present for ADHD services during the transition from adolescence into adulthood helps us ask smart questions and anticipate needs. Understanding how ADHD symptoms shift at this developmental stage improves our detection of hidden features and compensatory strategies that come at a cost. Using developmentally sensitive measures helps us recognize when symptoms are excessive for a particular age group. Referring to key DSM 5 changes for these older adolescents and adults guides accurate diagnosis of ADHD, even when childhood symptoms are less evident in adulthood. Awareness of increased vulnerabilities across domains informs our initial consults to gather all necessary information, as well as improving our treatment plans to target areas that need attention. Expanding our professional toolkits enhances our ability to help each person who seeks services, including guiding a balanced life and a teamwork mentality. Thank you for being here today. I hope this information will be helpful in your work with adolescents and young adults who are seeking ADHD related services. Let's take a look at some questions.
Dr. Sparrow, we have a couple of questions for today. So the first one we have is, can you discuss any recent research findings on the long-term outcomes for individuals with ADHD who receive early interventions versus those who do not?
That is a great question. Because really, most of what we do boils down to not what labels we give or what treatment plans we write, but how it affects the life of the individual we are serving. In terms of what the research says about early intervention for ADHD, it's similar to most everything we do, that early intervention can make a difference when it's targeted and appropriate. The research that I'm aware of off the top of my head shows better social outcomes, emotional outcomes, fewer of the disruptive behavior complications, often better academic outcomes. Early intervention usually does have a positive outcome for ADHD individuals. I think some key reasons that this helps is you reduce secondary factors. So things like if you're working on self-esteem and positive social interactions, you have fewer triggering issues for areas like anxiety or depression. You reduce some of those risk factors. That early intervention also a lot of times includes really good resilience work and coping strategies. So you're at the same time as reducing risk factors, you're building protective factors. I'm not aware of any studies that show a negative impact of early intervention for ADHD. So if you've got someone earlier than adolescence and you think they have ADHD, of course, you're going to work on it. Great question. Thank you.
Thank you for answering that question, Dr. Sparrow. The next question we have is, what are some effective ways to address the social challenges faced by young adults with ADHD, particularly in forming and maintaining relationships?
Another really good one. Oh gosh, it's really hard for me because I find that each individual presents with a unique combination of their own strengths and their own challenges. I don't know that I can give you a one answer for this. I can tell you I use a variety of strategies in my therapeutic work with individuals and with families. He- Um, I often use a blend of strategies like being a social detective. Especially noticing things like when I do this, people respond in this way. Some really interesting twists you can do on that. You can use television shows, watch clips of television shows to make observations of people's actions and reactions outside of a personal context. That's a way you can bring in situations to a therapy session since you're probably not following around this individual in their everyday life at school or work or family. You can use role play. Um, you can take the old bug in the ear technique, where you would have been speaking into someone's ear microphone to coach them on the next step, but you can do a variation of that within a session where maybe you have them and a family member where you're pulling out sidebars and saying, hang on, what did they just say? And sort of coaching them through the steps. Um, Simple things like breathing, like getting in the habit of taking a breath before speaking. If you practice that, that goes a long way in buying an impulsive person a few seconds of reflection before they blurt something out. Sometimes it helps to think about visually passing a baton, looking at relay races and thinking about conversations working that way, where you're thinking about someone has to finish their lap of the race before you grab the baton and begin your lap of the race. If you're meeting live, you could even do some running. The adolescents might be more interested in that than the adults, but you can ask. Sometimes just coming up with scripts of, I've got a stack of post-it notes here on my desk, and I'll talk with people about we're not going to write a script this size or this size. We're going to write a script this size because that's something I can remember. And that's going to be my placeholder of what I say instead of impulsively blurting out other things. It's a placeholder of, I'm not sure how I feel about that. Let me give it some thought or whatever fits the situation. Lots of modeling. If you have a family that is relatively intact and healthy, you can work on some modeling there. Sometimes parent coaching can be helpful for the adolescents or spouse coaching when you're working with an adult. Uh, in terms of just changing conversation patterns, because it's not always about the person with ADHD. Sometimes we need to change aspects of their environment to help them be more successful in practicing new skills. Um, a lot of times I'll work out explicit guidelines. My clients and I will develop explicit guidelines, especially for things like emails and texting and posting on social media. Rules like how long do you wait before responding? Um, how do you keep your response balanced with what the information was that came to you, so you're not having too much information or not enough information? Ways of checking with others when you're not sure how to respond. So just some really explicit guidelines that you develop as part of a partnership, not handing them these are the rules. Um, and then I've already said this, but let me repeat it. Always considering the co-occurring conditions that could affect those social interactions, especially things like anxiety. I hope that helps. And I'm sorry I don't have a really quick and easy, this is the one thing to do. I think it really comes down to the individual and where their strengths are and where their needs are. And that's how I develop which strategies I'm going to use with someone.
Absolutely, Dr. Sparrow, and thank you for the detailed explanation. We have two more questions, and the second last I have is, how can professionals effectively utilize comprehensive information about impairment and
Mm,
outcome to support adolescents with ADHD as they transition into early childhood,
mm,
considering the diagnostic and functional challenges highlighted?
mm. Okay. Good question. And I have to tell you, I don't know if you could read my body language. That was my least favorite part of the presentation because it's really hard to talk about negative outcomes. So why does it matter? Why did I drag you through that? Why did we spend time on that? Um, I think as a clinician, it's important because if we don't know about the risks, we don't know what to pay attention to. Often I find in my work with individuals and their families, they may not connect A to B. They may not realize that these things happening in everyday life could be related to ADHD. So I think it's really important for us to be smart so we know what smart questions to ask. So you might find it helpful to go through those impairments and make a sort of cheat sheet for yourself of I want to make sure I ask about these areas when I'm working with adolescents and adults, especially those young adults that we focused on today, so that we can pay attention to these areas so that we know what to consider in terms of level of functioning as well as level of risk. I think the process of asking those questions also raises awareness for the individual and whoever else is participating in the conversation. In the case of adolescents and young adults, you'll often have a parent who's involved. So I think the more we're aware, the better we're going to be at being proactive. Hey, that also helps us educate the teams of professionals around these individuals with ADHD. And again, we're going to come back to the reason we ask about risk factors and impairments is so that we can build in protective strategies and we can recruit appropriate team members so this person is not just out there on their own trying to figure it out. Hopefully that helps you know why we spent so much time talking about negative outcomes.
Of course, thank you. Thank you for the answer.
Yeah.
And the last question we have is shame based avoidance seems to be a common problem for adolescents and young adults with ADHD. Do you have any guidance for some ways to prevent that spiral? Would having an accountability person other than a parent perhaps be recommended, like a counselor, coach, or peer advisor?
Hmm. Interesting question. I read something recently about shame-based avoidance, and I can't quite place it. It'll come to me tonight. But I think, you know, I so the idea of having again those protective factors in place and thinking about the whole person. Um, I don't want anybody to experience shame. I don't want anyone to have shame, whether they have ADHD or not. I really would like to help every individual at any age be able to process that this is something coming from another person and I can have boundaries. It doesn't have to be my thing. I can, maybe I'm not good at this thing, but I don't have to feel ashamed about it. So, absolutely, for someone with ADHD, it's essential that we really beef up those protective factors and strategies for dealing with when someone's trying to shame you or when someone's saying something neutral and you're interpreting it as shame. We do want to help with that, the lenses that you're looking through and the way you're hearing things in terms of how you process that, because we don't want to start that spiral. In terms of an accountability person other than parent, um, I think in most cases it does help to have a qualified mental health provider who is outside the family system, who can sort of give you that bird's eye view and suggest some strategies for communication, both in terms of how you receive and how you express. But again, it depends on the individual. Not everybody can afford services. Not everybody has the wherewithal to consult services. Not everybody has a schedule where they can meet with a provider. You mentioned possibly a peer, and I think I would hesitate there unless it was a peer who was receiving support from an outside qualified provider.
Thank you so much, Dr. Sparrow, again for this information and for this wonderful presentation today. I would like to thank all our attendees who joined us. If we did not get to your question in this webinar, please send us an email at marketing@mhs.com and we will forward your questions along to Dr. Sparrow. On that note, we are at the end of our webinar and I wish all of you a nice rest of your day.